Our objectives include the ability at the end of this presentation to incorporate knowledge of the normal variation in growth and development into your pediatric practices, to identify patients who warrant initial evaluation for short stature or slow growth, and to understand available treatment options, including growth hormone and other newer therapies. The outline of our talk will begin with a discussion of variations in growth patterns, and starts with the notion that genetics really accounts for the great majority of that variation, assuming that all is well in terms of hormone secretion, nutrition, and skeletal development. Here is pictured as Wilt Chamberlain and Willie Shoemaker, both American Express card holders for many years in this ad from years ago now, and a more recent cover article in Science that dealt with the genetic underpinning of variation in the size of canine breeds. Now, bringing you right up to date to October 2014, the GIANT consortium, genetic investigation of anthropomorphic traits, includes literally a giant number of investigators and a giant effort. And it's based on the fact that height is a heritable trait with estimates stemming from twin studies, family studies, and the like, estimating that almost 80% of the variation in adult height has a genetic basis. So this consortium has come together with over 400 investigators across the world to look at common genetic variants, single nucleotide polymorphisms, or SNPs, and their association with variations in height. In a very recent publication, a genome-wide association study of some 250,000 subjects, a meta-analysis of several different studies coming together, statistical significance was seen for over 700 SNPs at 400 chromosomal loci. And those accounted for nearly 20% of the variation in height. Whereas if you combined all of the SNPs, even ones that weren't quite as statistically significant, it came up to approximately explanation of 60%. So those studies really offered some new biologic insights, or hopefully will offer new biologic insights, in that there were previously unsuspected genes that were involved in this variation and unexpected pathways. So as more and more research goes into this area, we will, as clinicians, be able potentially to tap into that information in the long run, and perhaps even have new therapies for growth disorders. When we, in our offices, see children with growth disorders, or parents who are concerned about their children's growth, one of the things that we do is to calculate their genetic target height. For girls, this represents an average of the mother's height and father's height, but first taking 5 inches away from dad so that he would be at a comparable position on the female growth chart. Boys, it's just the opposite. It's the father's height plus the mother's height plus 5 inches, and taking the average of that. But I want to underscore that this is a range. You wouldn't expect every single child in a family to hit the bullseye, to hit the middle of that range. There's quite an extensive variation, even in families, to the tune of maybe 3 to 4 inches on either side of that midpoint, that genetic target height. So that's important to understand, because many families come in and express their consternation that their son or daughter is aiming towards a height that is not the expected average based on what they would expect based on their genetics. And it's important to know that there is considerable variation that's well within the normal range. Here is a plot of both height and height velocity by age for girls in pink and for boys in blue. And I've chosen those lines that represent the height trajectories that are at the 50th percentile and that represent an average timing of the pubertal growth spurt. And what you note here is something I think we all appreciate as pediatricians, but also as parents. If you've had someone in junior high, that girls typically have their growth spurt about 2 years earlier than boys on average. So this is something that I think we can use to begin to look at this variation in the timing of puberty. If we were to look at bone ages in normal boys and girls, these are the standards from the typical Grulich and Pyle Atlas. And if we were to ask which sex is more mature at 14, at least in terms of skeletal development, what you see here in the distal epiphyses in the female is that these growth plates are already fused, whereas in the boy's hand, they're still open, still room for growth. How about if we look a little bit earlier at 11? What you see here is that in the girl's X-ray, there's already what is called capping of the epiphyses. In other words, kind of an overlapping of the epiphysis and the metaphysis, kind of the first step towards epiphyseal fusion. And you can see that perhaps most clearly in the radius, but also in the phalanges as well. That's not seen in an 11-year-old boy. And finally, what's perhaps most interesting is if you look as far back as 5, you see some differences. In the boy, there are 5 carpal bones that are ossified, whereas in the girl, a typical girl at age 5, all 7 of the carpal bones are already seen on X-ray. Plus, she's already engaged, so it's an easy answer to tell who's more mature at age 5. But think about it. If there is a boy or a girl who is a late bloomer, it might already be playing out in terms of their growth trajectory at a fairly early age. That's something that's shown here. Now we're focusing on a chart just for boys, and not only are we showing the boys that have their growth spurt at the average age, which is the yellow line, so maybe peak height velocity between 13 and 14, as shown here by the steepness of the height trajectory at that age. But we also see a boy who would be an early maturer, as shown in green, and a late maturer in terms of the red line here. And what's worth pointing out, and again, I think something we all recognize, is that even within the cohorts of normal, healthy kids at these ages, there can be tremendous variation in height, even if that variation narrows considerably by the time growth is complete. So you could have boys who are perfectly healthy at age 14 who are 20 centimeters, 8 inches different in height, who in the end are going to be very close to each other in height. So that's pretty striking in terms of looking at this format, but even more so, I think, when we look at these photographs. These are 14-year-old boys as pictured in one of Jim Tanner's classic works from this one from the 1990s, but looking back on some of his classic studies in the UK in decades leading up to that. The boy in the middle, kind of a typical 14-year-old. The fella on the right is much more mature in terms of pubertal development, much closer to his adult height now. And that's something that we can tell from his pubertal status, and we could also tell from his bone age. It would be rather advanced. In contrast, the fella on the left, who also is a perfectly normal, healthy 14-year-old boy, really is just barely getting out of the blocks in terms of pubertal development and has a lot of growing left to do. And if we think about the fact that these 3 fellows might be sitting next to each other in 8th grade English or going out for the same football team or the like, I think this variation is really quite striking. So one of the first practice points in terms of our presentation of growth and growth disorders is that it's important to explain to family the impact of this normal variation in growth. And that can, in and of itself, often provide reassurance to parents and to children as well. On the other hand, it's important to look out for, quote, red flags, and that would include children that come in and have either neurologic or GI signs or symptoms. If there's a negative family history, in other words, if the child that you're seeing is delayed, but there's not anyone else in the family who's followed that same path. And I think what's true in essentially any medical condition is the greater you are away from the norm in terms of either height or puberty or blood pressure or whatever it may be, the more intensive the evaluation becomes. So we're going to next look at how growth in general, or growth overall, is really can be seen as an integrated measure or index of health. And we're going to show a case in which a non-endocrine disorder has an impact that's significant on growth. So a girl of 15 years presents to her pediatrician and then is referred on to a pediatric endocrinologist. You'll see her growth chart in just a moment. She's short for 15. She has delayed puberty. She has some early signs of pubertal development, stage 2 breast and pubic hair development, but still has not had a menstrual period. Her review of systems essentially is unremarkable. Her bone age is quite delayed at 10.5 years, and, quote, screening labs were normal. And by that, I mean that her gonadotropins, estradiol levels were low, as if she had not yet entered puberty. IGF-1 as an index of growth hormone secretion, thyroid function tests as an index of thyroid function, complete blood count, SED rate were all normal. So let's look at her growth pattern. As you can see, she was tracking close to the 25th percentile in height up until about age 10, at which point her growth slowed considerably and took her to a position well below the 5th percentile by the time she's 15 years of age. As I've shown here, we've plotted the height not only at chronologic age, as shown by the yellow circles, but also at her bone age, as shown by the triangle. And that's an indication that her growth potential, her remaining growth, is really quite substantial at age 15. And if we can sort things out, she has the potential to reach a very normal height for her genetics. Her genetic target height range is indicated by the yellow rectangle here. It was therefore deemed, as a result of her workup, that she likely had constitutional delay of growth and development, and given that she was already 15, quite short, and really very little in terms of pubertal development, was administered low-dose estrogen for a period of time. And at a return visit, showed really only modest increases in height and breast development and a very minimal increase in weight. And importantly, going through the review of systems again, there was a new complaint, that of abdominal pain and diarrhea, and that caused us to look at her weight pattern. And as you can see, she was never really low in terms of her weight for height. But back when she was 4, 5, 6 years old, her weight was quite a bit higher on the chart than it ended up at. And it looks like the flattening out or the slowing of her weight gain occurred even earlier than did the slowing of her linear growth. So with the complaint of some GI symptoms, some additional testing was done, and the diagnosis was made of celiac disease. And as you can see here, there was a dramatic response of both height and weight, as well as pubertal development when a gluten-free diet was introduced. So, second take-home point is that it's important to plot growth data. I think that's something that all pediatricians are familiar with. But it's important to look at BMI, not just to identify those who are at risk for overweight or obesity, but those who are declining on the BMI chart in terms of those standards. And it's therefore important to ask what's predominantly affected in those children in whom growth is a concern, linear growth or weight gain. It's also important to note that there are several diagnoses or conditions for which there are specific growth charts, including Turner syndrome, Down syndrome, in which short stature is really one of the cardinal features. And yet it's still worthwhile knowing, is this girl with Turner syndrome growing appropriately for other girls with Turner syndrome? Because that will sometimes be helpful in identifying additional problems that would need to be addressed. Kind of a correlate of this is that some non-endocrine disorders can manifest as suppression of growth and or puberty before they, quote, show their true colors. For instance, GI disease in the form of celiac disease or inflammatory bowel disease can influence growth even before there are GI symptoms. And therefore, in recent years, we and other pediatric endocrinologists include specific screens for celiac disease, as well as more non-specific screening tests like SED rate and CBC to look for iron deficiency, to screen for the possibility of inflammatory bowel disease. The next topic on our outline we'll go through rather quickly. It's not something that is seen as commonly in general practice, but is still worth noting. And it's worth noting because all of the other things that we talk about, systemic health, adequate nutrition, normal growth hormone secretion, all of that depends on kind of a normal skeletal substrate being able to respond to those influences. So if we were to focus for a moment on primary skeletal dysplasias, this represents a somewhat simplified diagnostic approach. You can look at body proportions, and we'll talk about the specifics of that in just a moment. And if they are normal, you're most likely dealing with either an endocrine disease like growth hormone deficiency or hypothyroidism, or systemic disease like celiac disease, or so-called idiopathic short stature, normal, healthy child who is short. However, if body proportions are abnormal, it may be an indication of one of more than 100 different primary skeletal dysplasias. And therefore, it's worthwhile doing just a few simple measurements, because you can go down a pathway that really can take you pretty far in terms of a differential diagnosis. You can look at whether the spine or axial skeleton is affected more so than the long bones, the bones of the arms and legs. And if long bones are affected more, is it their proximal segments or their distal segments? So therefore, from fairly simple measurements can be helpful. Starting with a head circumference, which is certainly part of the normal pediatric practices in young kids, but can also be important in older kids who present with concerns about their growth. And then looking at how body proportions measure out. In this classic drawing from Leonardo da Vinci, what's depicted here in the white arrows is that arm span and standing height are usually within a couple of inches of each other. And again, what you're looking at there is long bones in the arms, long bones in the legs, the spine, combination of those things in order to get a value that is comparable to standing height. If you measure from the pubic symphysis down to the floor, so-called lower segment, and express that as a ratio, the upper segment above that line relative to the lower segment below that line. Obviously, in young kids, that ratio is significantly greater than 1. And by perhaps age 8 or 10, it reaches unity, and then becomes less than 1 in teenagers and adulthood. If those ratios, that arm span to height picture, does not fit with these expectations, it could be a clue to a skeletal dysplasia. And there are increasingly important insights about the molecular basis for some of these, so we can take it to the next step and do some genetic analyses when it's appropriate. Next, let's talk about really the meat of any endocrinologist's talk about growth, which are endocrine disruptions of growth. And we'll talk about them very broadly at first and then focus in on growth hormone deficiency and its therapy. Here, if we look at all of the hypothalamic pituitary endocrine axes, growth is something that is an output or an endpoint of all of them. You need adequate thyroid hormone in order to achieve normal growth. On the other hand, too much cortisol, as is true in Cushing's syndrome, or is true when patients have to be treated with high doses of glucocorticoid long term, that suppresses growth. The rise in sex steroids at the time of puberty obviously causes secondary sexual development, but is really part and parcel of the pubertal growth spurt. And then finally, we'll focus on the growth hormone system. As shown here, and as we'll talk about again in a few minutes, growth hormone release from the pituitary is a combination of stimulation by a releasing hormone, GHRH, as well as an inhibitory factor, somatostatin. Growth hormone elaborates the production of IGF-1, insulin-like growth factor 1, both in the circulation from the liver, but also right on site at the level of the growth plates. And it's IGF-1 then that is thought to be the predominant factor that influences growth at the level of those epiphyses. So we're going to focus on growth hormone now for the rest of our talk. Growth hormone deficiency from a clinical standpoint might be considered if there has been birth trauma, either asphyxia or physical trauma during the delivery. If the child presents with some midline CNS defects, these might include septo-optic dysplasia or encephaloceles, or even midline defects of the face, like cleft lip and cleft palate. It seems as if the development of facial structures as well as midline brain structures are occurring right around the same time. And if there's been an influence that affects one, you might see influences on the other systems as well. If little boys have microphallus or if infants have hypoglycemia, that can also be a tip to growth hormone deficiency. And those things would be more commonly seen if there were multiple pituitary deficiencies. In other words, if there was growth hormone as well as GnRH deficiency in a boy with microphallus, if there was growth hormone and ACTH deficiency in an infant with hypoglycemia. In terms of the growth correlates or growth dynamics, really the hallmark of growth hormone deficiency is delayed or decreased growth velocity for age. And this can occasionally mean that a child who has been growing at the top of the growth chart slows down such that they're now at the middle of the growth chart. So it's not always the absolute height that is important, but rather an estimate of the rate of growth that is really key here. And we really do our best to try to get the past data from you, from the family, that will allow us to take a look at that. The bone age is typically delayed, and interestingly, the BMI is often kind of on the generous side. Growth hormone is anabolic, It's involved with muscle mass and muscle development, such that kids with growth hormone deficiency classically are a little bit on the chubby side and therefore often have a BMI that's on the upper part of the chart for their age. Having said all of this, if the clinical features suggest growth hormone deficiency, the next steps are somewhat of a challenge. The diagnosis in terms of biochemistry is made that much more difficult by the fact that growth hormone, like a number of the pituitary hormones, are characterized by a pulsatile pattern of secretion, as shown in this figure. What's more, there tend to be more and higher peaks at night, such that during the daytime, the levels are often low. And therefore, if you were to take a single random daytime sample of growth hormone, it's very difficult to distinguish an abnormal profile, as shown here by kind of a flat line in red at the low levels, versus a normal profile that has the peaks and valleys seen throughout the day. But more often than not, you spend your time in the valleys. So in other words, a low growth hormone level measured randomly during the daytime really does not help with the diagnosis of growth hormone deficiency. And therefore, we really depend upon looking at the integrity of the growth hormone axis by measuring two growth hormone dependent proteins, IGF-1, insulin-like growth factor 1, and one of its predominant binding proteins in serum, IGF-BP3. In the setting of growth hormone deficiency, you would expect both of them to be low, and more importantly, in terms of our discussion about pulsatile secretion, they would be rather steady during the day, so that a single sample would give you a fairly good indication about what's going on. Like anything else, there's some ifs, ands, or buts about fasting and nutritional perturbations that can sometimes make the interpretation of IGF-1 levels somewhat of a challenge. Here's another case. Again, short stature and delayed puberty. And this patient was sent in with some lab values already having been obtained that included an IGF-1 that was low for age at 151 nanograms per ml. And you can see that in the age range of 12 to 15, the normal range for IGF-1 at the low end is about 200. And you can see clinically that here, again, is a fellow who was growing at about the 25th percentile, and then by age 11 or 12 has started to slow, such that he is now just below the 5th percentile at age 14 with a delayed bone age. Another way to look at his maturational status, in addition to the bone age X-ray, is obviously Tanner staging. And this fella is still prepubertal, and that was borne out by the biochemistry. His gonadotropins and testosterone are still very low. Well, I think we all learn about endocrine axes one at a time. We learn about the thyroid system. We learn about the growth hormone system. We learn about the reproductive system. But in reality, all of these axes really interrelate to each other in the body in very important ways. And puberty and growth are no different. So when there is a rise in estradiol or testosterone at the time of puberty, that increase begets or causes an increase in growth hormone secretion, which then increases IGF-1 levels. I think you can see where I'm going here. If you have a boy of 14, an age where you typically expect the pubertal growth spurt to be underway, and yet he's prepubertal, you really have to look at the more relevant comparison group, which for this boy would have been the group of boys who are still prepubertal. And now you can see that his IGF-1 value of 151, which was low for age, is within the normal range, albeit on the low end, for a boy who's still prepubertal. So the question, is this growth hormone deficiency, I think would be answered in this instance, probably not. And what's far more likely is constitutional delay of growth in puberty. Now, I don't want to indicate that that's not reason to look into things further. Every once in a while, a boy or girl that has a trajectory not unlike this will be harboring a craniopharyngioma or really something worrisome that is at the heart of their growth delay. So it's certainly very important to kind of take a big comprehensive view of things in terms of your history, family history, physical exam when you're seeing children who present with these concerns. So there are certainly times when the growth hormone status of a patient is not answered very clearly by IGF-1 values or their growth pattern. And as you well know, endocrinologists like to kind of tweak systems and see how they behave. And that's no different when growth hormone is the focus of our attention. So there are provocative tests, stimulation tests of growth hormone secretion that involve either the administration of growth hormone releasing hormone or actually more commonly medications that stimulate the release of growth hormone releasing hormone. In other words, things that are going to step on the gas, cause growth hormone to go up. Now, if that were to happen, and you just happen to be in a phase where somatostatin tone is high, you might not see a very impressive growth hormone peak. And therefore, a number of testing strategies involve the addition of medications that will serve to inhibit somatostatin tone. In other words, take the brakes off. And frequently, as I said, we combine those two types of stimuli in growth hormone stimulation testing. Now, for any family that has come in and spent a morning with us, several hours with an IV in place, a dozen or more blood samples over several hours, you would expect this to be the ultimate way to diagnose a problem with growth hormone secretion. But it's still not so easy. As we've mentioned already, growth hormone secretion is pulsatile. The interpretation of IGF-1 and BP3 levels require the developmental perspective that we talked about before. And even growth hormone stimulation tests are somewhat problematic. You're stimulating the pituitary with a clearly pharmacologic stimulus. So there's some settings in which individuals might not have normal growth hormone secretion on a typical day, but if you hit the pituitary with a sledgehammer, you'll get a burst of growth hormone release. Importantly, there's variation within an individual. Growth hormone assays can yield somewhat varying results, such that in one assay, one laboratory, the peak growth hormone response may exceed the threshold for a normal response, a normal test. And in another assay, it might fall just shy of that. And what's more, there aren't a lot of normal, healthy kids that have been suggested to this type of testing. So therefore, the cutoffs are somewhat arbitrary in terms of what constitutes a normal growth hormone response. With that in mind, some pediatric endocrinologists have argued, why are we even doing this? Why don't we use other clinical and laboratory and X-ray features in order to get insights into this? So Darrell Wilson and colleagues at Stanford wrote a piece some years ago that proposed that if a child is growing slowly and there's clinical suspicion, therefore, of growth hormone deficiency, it would make sense to measure IGF-1, IGF-BP3, look at them relative to the appropriate standards for age and puberty, and if low, really look into the underlying reason for why growth hormone deficiency might be present. And we'll talk about the utility and importance of cranial MRIs in just a moment. And you could also bring to the table some, relatively new advances in pituitary development that include a number of transcription factors that are required for normal pituitary development, normal growth hormone secretion, normal growth hormone activity. And if these things are abnormal, you would have, I think, every reason to think that that child might be or is growth hormone deficient, and perhaps has other pituitary hormone deficits as well, and therefore would be a candidate for growth hormone therapy. If the initial screens were normal, you may well be dealing with a child who has idiopathic short stature, or a systemic disease like celiac disease, as we saw a moment ago, or you might be seeing something that's evolving. I think it's always important to remember that some of the conditions that we see have a natural history to them, and when you first investigate a child with a growth disorder or a seeming endocrine condition, and if the results are somewhat borderline, it's important to continue to observe that child in terms of their growth and development and other relevant endocrine characteristics, and see if something is going on, see if something is evolving over time, because you certainly would not want to miss, for instance, an acquired CNS lesion. Well, while some have advocated for this approach, in other words, growth hormone stimulation testing, so troubled that why do we even do it? When you look at the reality of the situation, as is shown here by the criteria that are put forth by just one major insurance company in terms of who would qualify for growth hormone therapy, you see that a stimulation test in which a peak growth hormone level less than 10 nanograms per ml really is a criteria for their approving growth hormone therapy in the setting of growth hormone deficiency. I personally think that stimulation testing is worthwhile, because if the response to a growth hormone stimulus is abnormal, I think that really does cause us to look into the underlying issues further and more intensively in that particular child. Before we go on, what about MRIs? Why do we do them? Well, in part, it's because in some patients who have growth hormone deficiency, it's a congenital condition that has to do with abnormal development of the pituitary. This is a mouse embryo from very early stages of gestation, and the line drawing above shows that same level of development with the outpouching of the oral ectoderm, Rathke's pouch, growing upward, and the base of the brain, what will become eventually the pituitary stalk and posterior pituitary, growing down from the midbrain. And as we go back to the histologic section, you can see that now highlighted in blue and red. And those structures become the anterior and posterior pituitary. Now, in some patients who have growth hormone deficiency and other, with or without other pituitary dysfunction, you may see a developmental defect. So here is a normal MRI on the left-hand panels. You can see the pituitary stalk and a pituitary bright spot in the appropriate position. That bright spot is thought to represent a normal posterior pituitary. The granules or secretory granules of vasopressin or antidiuretic hormone are thought to be what causes that characteristic MRI picture. And here in a different view is the pituitary stalk and a normal-looking pituitary. In contrast, here you see a relatively small anterior pituitary. You don't see any pituitary stalk, and the posterior pituitary bright spot is high, still at the base of the brain, as if those two structures developmentally never met up and formed a normal pituitary. And that's perhaps even more clearly seen here, where you don't see the pituitary stalk and you do see the ectopic posterior pituitary. So not only are you looking for hints as to what might be underlying the growth hormone deficit, but you're also, perhaps even more importantly, looking for acquired CNS lesions like a tumor that would be affecting not only growth hormone but other axes as well. So in terms of our diagnostic approach, let's go through this, and we'll kind of characterize these diagnostic steps according to whether they would be indicated pretty much in any child who has a growth concern or in selected patients. So obviously a good physical exam in terms of the stages of puberty, as well as a bone age x-ray. A targeted history and physical in terms of their neurologic status, and if there's anything worrisome, an MRI. Screens for systemic disease, including the specific screen for celiac disease, I think have clearly now become appropriate for almost any child who you have concerns about. Assessment of the growth hormone axis, again, begins with measurement of IGF-1 and IGF-BP3 because you can get some pretty good information from a single sample obtained any time of the day or night. But in contrast, growth hormone stimulation tests are something that we really proceed with only when we have a relatively high level of suspicion. If the IGF-1 was low, if growth rates were really quite profoundly slow, and perhaps most classically the combination of those two things. Other endocrine systems are important to evaluate. Profoundly hypothyroid children do not grow well, and they have profound delays of skeletal maturation. So almost at any age, it's appropriate to look at TSH and T4. And just as a quick digression, I think it makes sense to look at both of those because you could have a problem with the central regulation of TSH, have TSH that's within the normal range, and have low free T4. In other words, central hypothyroidism. And if you measure only TSH, you're not going to see that. So it's important to look at this kind of from a systems perspective. And then in older kids, it's important to see where they stand in terms of the changes of puberty and perhaps even measure prolactin, because in rare instances, a prolactin-producing tumor in an adolescent may be the brake that's slowing pubertal progression. And then finally, in terms of karyotype and genetic tests, that's certainly not something that we do by any means in everyone. But in selected patients, a karyotype to look at Turner syndrome or to rule out Turner syndrome, specific analyses of the X-linked SHOX gene, which is thought to be really the reason why girls with Turner syndrome are short. And then, as I noted, there are a number of transcription factors that are involved in these developmental defects in terms of pituitary development. I guess it would be fair to say that the latter, these genetic tests for pituitary development, are not really standard of care. You would proceed similarly with and without that information, but it might, I think, be increasingly relevant with cheaper genetic testing and also with families in whom genetic counseling is going to be important in terms of other children that might be in their plans. So we'll finish up by talking about growth hormone therapy. And we'll start with kind of a look at classical growth hormone deficiency. The historical perspective here, I think, is important. Up until the early 1980s, all growth hormone was produced by purifying extracts of human pituitary glands. So having cadavers in which pituitaries were harvested and then distilling it down, so to speak, to the little bit of growth hormone that you would get out of each pituitary. Therefore, it was incredibly scarce. And one of the mandates that was a corollary of that was to use really as little as possible in any given patient, because if you were to do that, you would have some left over to treat the next patient. However, final heights in patients treated in this era remained well below their genetic target. And finally, right around the early to mid-1980s, as I think most of you are aware, cases of the very rare prion disease, Creutzfeldt-Jakob disease, emerged and were shown to be linked to use of human pituitary growth hormone. So with that insight, human pituitary growth hormone, cadaveric growth hormone, essentially disappeared from use. But let's look at what that era was like. These are two brothers who were treated by a colleague of mine, a senior colleague, in whom brother number one wasn't referred or diagnosed with growth hormone deficiency until he was about 6 years old. You can see he caught up very nicely, but in the end remained considerably shorter than what would have been expected based on his father's and mother's height. So with that in mind, the younger brother was scrutinized very carefully, and the fact that he was already well below the 5th percentile by the time he's 2 led to an evaluation, his diagnosis with growth hormone deficiency, and the beginning of his treatment. And even in the setting of this relatively early diagnosis, he did not really reach an adult height that was expected of him. Now, turn the clock ahead now 3 decades, and we have the current state of the world, which is that human recombinant growth hormone was approved by the FDA, clinical studies initially by Genentech and subsequently by Eli Lilly, resulted in the approval of their products right around the time that the cadaveric growth hormone was seen to be the source of this very troubling rare neurologic disease. So now we're in an era in which growth hormone is limitless in terms of its supplies. Now, limitless and price don't necessarily go together. It's still a very, very costly therapy. But with this limitless supply, you can now have your attention be focused on what is the optimal regimen for an individual in terms of dose, frequency of administration that would allow for them to achieve an adult height that's in keeping with their genetics. And I think it's fair to say that the doses are higher in the current era. Daily injections now are the norm, whereas in the previous era, it had been very common for it to be administered every other day, 3 times a week, something of that sort. So here's data that looks at the height outcomes in patients with idiopathic growth hormone deficiency. In other words, no evidence of an underlying CNS defect. What's important to point out here is that there are 2 box plots. The shaded one represents patients treated with growth hormone alone. The open box, a much, much smaller number of patients who were treated with the combination of growth hormone and a GnRH agonist to delay puberty, with the notion being that maybe you could buy a little time if you suppressed puberty, kept the epiphyses open, and allowed more time for growth. And here you can see that compared to the population average, the near adult height, in other words, these kids may have had a few centimeters left in them, but they were almost done growing and they still fell shy of the population standards. But once you take into account their genetic target heights, in other words, this must have been a cohort whose parents weren't so tall either. Now, in this current era of recombinant human growth hormone treatment, kids end up at final heights that are very close to their genetic potential. And the addition of another, by the way, very costly medication, the GnRH analogs, seems to have a very modest impact on adult height. Now, as I'll close our talk in just a minute, there may be instances in which combining therapies like growth hormone and a GnRH agonist might be appropriate for an individual, but it's by no means something that would be done routinely. So, finishing up here, growth hormone therapy for really since around the late 1950s, early 1960s, has been shown to be very helpful in patients who lack growth hormone. But in the current era, where growth hormone supplies are limitless, you can kind of expand your vision, your horizon in terms of what might be an indication for growth hormone therapy. And that might include, in some instances, some primary growth disorders. And on that front, I'm including Turner syndrome and patients with the SHOX defect. And over here, in terms of systemic conditions, what is one of the FDA-approved indications, chronic renal failure. So there's a notion that growth hormone therapy has expanded beyond the realm of growth hormone deficiency per se. Let me just show you a little bit of data from Turner syndrome, which is now quite old, but I think is still nevertheless makes the appropriate points. I had mentioned before that there are diagnosis-specific standards for certain conditions. So these solid white lines are what would be expected for girls with Turner syndrome in whom no therapy is introduced, either growth hormone or estrogen replacement. And here in a group of maybe a dozen or 20 or so girls with Turner syndrome, at the outset, before any intervention, they had variable heights. All of them were short relative to for their age as compared to the typical normal standards of height in the United States. But they were on average in height for girls with Turner syndrome. Roll the clock ahead several years, and each of these girls was treated with growth hormone in the interim, and now some of them are on the chart, meaning the normal standards at the 5th to 10th percentile or so, and on average they're tall girls for Turner syndrome standards, and that has been taken to be very good evidence that growth hormone therapy for this particular condition is beneficial. And I think with maybe some folks arguing the absence of relevant contemporary controls being problematic, I think for the most part it's fair to say that growth hormone therapy in this situation is considered standard of care. If we were to look at FDA-approved indications for growth hormone therapy, we have growth hormone deficiency. It won't be the subject of today's or this lecture, but even adults with growth hormone deficiency are considered candidates for therapy now because of growth hormones' metabolic effects, anabolic effects on bone, and positive effects on body composition. Turner syndrome, Noonan syndrome, patients with proven SHOX abnormality, as we said, patients with chronic renal failure. Prader-Willi syndrome gets an asterisk here because it is increasingly thought, I think by most of us in the field, that those patients do have hypothalamic dysfunction and deficient growth hormone secretion, although their obesity has sometimes kind of gotten in the way of clear evaluations of their growth hormone status. Growth hormone responses tend to be lower in obese kids, so I think we wrestled with whether children with Prader-Willi syndrome had inadequate growth hormone responses because of their obesity or because there was true growth hormone deficiency. These days, growth hormone stimulation testing isn't even required to begin therapy in that setting. Children who were born small for gestational age and fail to catch up by the time they were 2 years old or so are potential candidates. We won't touch on the use of growth hormone in AIDS wasting syndrome, but that's kind of indicative of other conditions, recovery from severe burns, recovery from other catabolic states where growth hormone has at least been investigated, if not come into the mainstream. But what we're going to talk about for the last few slides now is idiopathic short stature, which received FDA approval about 10 years ago now, in 2003. So here's a question that I pose to my families, pose to our trainees in order to begin this discussion. If you have normal growth hormone secretion, could more growth hormone make you grow taller? And I would say Exhibit A, in terms of that question, is this fella here, standing with his graduating class in Alton, Illinois in 1936. Robert Wadlow is referred to as the Alton Giant, and at least until recently, he was in the Guinness Book of Records as the tallest man ever with a recorded height. You can see here that he reached a height of almost 9 feet tall and was a big guy. Here he's standing with his normal brother. So can more growth hormone make you taller? Yeah, in the setting of pituitary gigantism, that is a proven fact. However, Robert Wadlow did not grow to be very old and healthy. He expired, as you see here, at a very young age. And as we all know, growth hormone excess is accompanied by a number of different potential metabolic consequences. So if you had a perfectly normal, healthy kid who was short, who met the criteria for idiopathic short stature, you certainly would not want to introduce a therapy that had significant potential side effects. And therefore, the growth hormone doses administered are much, much lower than what would be true in these very rare individuals with pituitary gigantism. Having said that, there have been studies looking at the impact of growth hormone therapy in these settings. This is one such study whose lead author was Ray Hintz from Stanford. It was, like many growth hormone studies, funded and undertaken under the auspices of one of the growth hormone manufacturers, in this case Genentech. All of the patients who entered the study were evaluated in terms of their age, their bone age, their pubertal status, and then started on growth hormone. And their outcome was compared to their original predicted adult height. That's what I've underscored here in blue. At baseline, the boys in this study were expected to reach a height of about 5'3", 160 centimeters, and the girls 4'10", 147 centimeters. The study went on for quite some time. The duration of therapy on average was 5 or 6 years. And after 5 or 6 years of daily growth hormone injections and then subsequent follow-up such that the boys and girls were 17 or 18 years old at their adult heights, the actual final heights in the boys was 165 centimeters, or about 5'5", and in the girls was 153 centimeters, just above 5 feet. So that the difference between their actual adult height and their original height prediction that would have applied if therapy had never been introduced was on the order, in both boys and girls, of about 5 to 6 centimeters, about 2 inches. Now, when you present that to families, it's interesting how some people say, you mean we could do shots for years and years and years and only end up with an additional inch or 2? Gee, that doesn't seem like it's worth it. And no offense to you, doc, but we don't like shots and we don't like doctors all that much either. There are other families that say, let's get going. Let's do the paperwork. Let's start yesterday in terms of growth hormone treatment. So then I show them the next slide, which is from that same study. And now what's depicted here is the final adult height relative to the original pre-therapy predicted adult height. If everyone in that study had ended up as tall as was originally predicted, all of the dots would fall right on the diagonal line. The pink dots for the girls, the blue dots for the boys. And yet, as you see, most of the dots are above the line and average about 5 centimeters above the line, 2 inches. But what's really quite clear is that there's a lot of variability here. If you just kind of focus in here, among the boys who were predicted to be maybe around 5 feet to 5'3", there's some that barely reached that original prediction, some that had the additional 2 inches, which is the average for the entire study group, and some that exceeded that and was twice that average. Now, it would be great to know what underlies that variability in terms of responsiveness, but to date, there's really no reliable way to predict benefit. And again, some families look at this and say, oh, so it's not even a guaranteed 2 inches. It could vary in my son or daughter. It could be the same as if we never treated him or her. And I say yes. And some of them say, well, doc, as long as they're healthy, that's good enough for us. And other parents say, let's go for it, without really any equivocation. So I think we'll just kind of close out this topic by saying this is a tough area. We as physicians, I think when we sit down with our patients, are advocates for their health and to treat them as individuals and as families. But on a societal basis, there are some broader implications for this. Growth hormone for idiopathic short stature raises all sorts of questions, medical, economic, ethical. Is short stature a disease? And if so, where do we draw the line? Should treatment be covered by insurance, remembering that we're all kind of feeding into the insurance pool? And what if growth hormone wasn't so expensive? What if you could administer growth hormone and it wouldn't be so costly? Would it then be appropriate to treat more short kids and have the threshold be at a different place in terms of considering therapy? And very importantly, what are the outcomes? I think it's fair to summarize what are really several studies of quality of life, happiness, friendships, and the like, by saying there's a difference between looking at those patients that come to our clinics and those folks that are surveyed out in the community. Out in the community, if you ask various different questions, do you have a lot of friends? Are you happy? Is life good? It doesn't correlate very much with height. Folks who come into the clinic, certainly there can be instances in which height is a major, major concern for them. And then the question is, does treatment make a difference? And I think that's a topic for a broader discussion, but there have been some data that suggest there really isn't that much of a difference, and others that suggest that there may be some benefit. So with that rather general discussion here, we'll turn to finish up our talk about growth and growth disorders with a quick discussion of what's new. So when there is a defect in growth hormone secretion, those are things that clearly respond to the administration of growth hormone. On the other hand, there can be deficits in the growth hormone receptor, in growth hormone signaling, in the IGF-1 molecule itself or its receptor. These are things that might be indicated by the fact that growth hormone levels, particularly in the stimulation testing, are quite high, but IGF-1 is low. In other words, states where there is a primary deficit of IGF-1. And they are not going to respond to growth hormone administration. There now is IGF-1 available for therapeutic use. Because of its kinetics, it typically has to be administered twice a day subcutaneously. And remember, IGF-1 gets its name because it's insulin-like in terms of its structure, and therefore at concentrations near the peak, there can be a risk for hypoglycemia. So these shots typically are given around mealtime in order to obviate that concern. It's just interesting from a medical legal standpoint that another company had a somewhat different strategy, combining IGF-1 and its binding protein so that the kinetics were more long-lasting and a single daily injection was possible. But this company sued this company in terms of their production processes, and it was deemed that Insmed had infringed on the patent of this company. I think it's fair to say that this has not taken off like a rocket in terms of our use in the clinic, but it's certainly very, very helpful in those rare patients who have what is deemed Laron dwarfism, which are patients who have a deficiency or mutations in the growth hormone receptor, and similarly rare patients who have mutations of the growth hormone molecule itself. You'd think that giving them growth hormone would be the perfect treatment, and it is, until they form antibodies to what is to them an abnormal protein, not native protein, so they can develop blocking antibodies. And in those two instances, I think it's quite clear that treatment with IGF-1 is beneficial. We'll finish out with this rare, but I think revealing case that was written up in the New England Journal now about 20 years ago. And it was the case report of a man who was tracking along his expected growth trajectory up until the time of adolescence. But then when he was 16 and 18 and 20 and 25 and 28, he was still growing. He was 6'8", and yet his genetic target height was about 5'8". He was well virilized, had normal testosterone levels in the adult male range, but his epiphyses were at least still somewhat open. He had a bone age that was typical of a 15-year-old boy. Now, this was an all upside in that he had what turned out to be severe osteoporosis and some other metabolic concerns in terms of his lipid profiles and insulin sensitivity. But it turned out that he had a mutation in one of the estrogen receptors. At the time, it was thought to be the estrogen receptor, but it came to be recognized that it was an estrogen receptor alpha. So he made testosterone, he made the little bit of estrogen that all of us males make, but he couldn't respond to estrogen. And as a result, his epiphyses never fused, and he kept on growing. So it led to this hypothesis that what if you could have testosterone rise, either because it was rising endogenously as puberty progressed, or because it was being administered, but you didn't have any conversion of that testosterone to estrogen. The key enzyme that makes that conversion is aromatase, and there are a number of medications in the class of drugs that are referred to as aromatase inhibitors, letrozole just being one of them. So perhaps you can kind of have your cake and eat it too. You could have the changes of puberty, but you could have buy some time for longer growth periods because the epiphyses would not fuse. As I said, this is not all positive, and you wouldn't want to do this for an extended period of time. But this is data from Leo Dunkel's group in Helsinki, Finland, that looked at the near final heights and gain in height in boys with delayed puberty who received testosterone alone, some of which was converted to estrogen in vivo, or testosterone in combination with letrozole, so that estrogen was very low in them. And as you can see here, it appeared to offer some potential benefit. Now, there are a lot of ifs, ands, or buts about actual final height and potential skeletal effects of blocking estrogen and a lack of long-term safety data. But this is just one example of things that are now opportunities for us in individual patients, and also to better characterize the pathophysiology and potential therapeutic approaches to growth and growth disorders. So there could well be individual patients who would be candidates for combination therapies, growth hormone or perhaps even IGF-1 to speed up growth, and the GnRH analogs that would suppress puberty, or aromatase inhibitors that would lower estrogen concentrations that would at the same time slow down skeletal maturation. Don't get me wrong, this is not something that we do routinely, but in certain individual circumstances, these combination therapies are something to consider and discuss as options. So in closing, the practice points that we touched on during our lecture today about growth and growth disorders include the fact that the impact of normal variation in growth and puberty really accounts for a lot of the patients who come in our doors. The normal kind of late bloomer that is shorter than his or her peers and is troubled by that fact. But you always have to have your antenna up. You have to be on the lookout for those clinical red flags that we spoke about. It's very important to plot out height and weight and take a look at that relative to the appropriate standards. And then be comfortable with the initial evaluations that would allow you to get a pretty good picture of that child's growth. And that would include a bone age x-ray, general screening labs like CBC, SED-rate, and screen for celiac disease, IGF-1, IGF-BP3 to look at the growth hormone axis, free T4 and TSH to look at the thyroid axis, and a look at the pubertal status of patients who are older. And finally, I hope it's clear to you that we have therapies now that are still relatively new, and with all the genetic opportunities and insights that we have in years to come, it's quite clear that we're going to have an expanded set of therapeutic options in children. But right now, growth hormone and other new therapies warrant at least a prudent, individualized discussion with families in those settings in which it seems like it's would be an appropriate